Hi, everyone. Welcome. My name is Nisha Bansal. I'm a professor in the Division of Nephrology at the University of Washington. I'm also the chair of this AHA statement on the evaluation and management of kidney dysfunction in patients with advanced heart failure.
Hi, my name is Wilson Tang. I'm a professor of medicine at Cleveland Clinic, Lerner College of Medicine of Case Western Reserve University. And we are really delighted to discuss this new AHA scientific statement on the evaluation and management of kidney dysfunction in patients with advanced heart failure.
And we want to give a special thank you to the American Heart Association for commissioning this statement. So, Wilson, perhaps you can tell us a little bit about why we decided to pursue this topic at this time.
Sure. Uh, uh, Currently, the guidelines and scientific statements have really recognized this important problem. But in-depth review of the current evidence and bedside conditions, as well as some practical day-to-day kind of recommendations are really lacking, despite the growth of clinical evidence and therapeutic options. So we actually wanted to, come together as a group, collaborating between nephrologists and cardiologists to try and decipher this, issue.
And what do you think were the main takeaways that we had from this statement? What were the main themes that came out?
We certainly divided this into four main points that hope to shift the mindset a little bit on how we conceptually, undergo the framework to assess, and evaluate and manage patients with advanced heart failure. We know that kidney dysfunction in advanced heart failure is best defined as the evidence of the kidney's intolerance to the heart failure disease progression. So the kidney is unable to maintain fluid and electrolytes, as well as the waste excretory and endocrine functions. We've always relied on glomerular filtration rate to estimate it, like the eGFR, which we know is strongly predictive of outcomes. You and I did a lot of research on that, but certainly that reflects the irreversible nephron loss. What we try to really emphasize is the heart failure related portion of the kidney dysfunction, which is reflected by the fluctuations of this change that we see day to day when we manage patients. Sometimes it goes up, sometimes it goes down, usually due to impaired perfusion and congestion in the absence of any prominent features of intrinsic kidney disease. We actually had a very nice figure in figure one that actually showed that, which actually drives the whole idea of this concept of single nephron kinetics. It's not just the nephron loss that we're talking about, but also the dynamics to which we may actually reverse or stabilize the process through stabilization of the renal blood flow by therapeutic options that we are going to discuss later on. Another big concept is the whole idea of kidney function itself is just not one single number. It's a whole myriad of things. So, of course, nephrologists taught us all the time about, looking at electrolyte disturbances, biomarker profile, sometimes even with imaging. For us, we are certainly focused on hemodynamic support, but all these trajectories that we see as we take care of patients, as we show in figure two of our scientific statement, shows us the importance of recognizing early in the phase so we could actually attend to. Obviously, volume optimization and improving kidney perfusion can improve this single nephron kinetics, and we actually outline in another figure, figure three, that shows all the options. So Nisha, what do you think about, as we go through the advanced heart failure therapies, what kind of considerations we do as to assess kidney function?
Yeah, thank you for setting the framework for assessing kidney function more broadly. And I think one of the places that we see this particularly important in terms of the considerations around kidney function are in those who are considering LVAD implant. And I think these clinically are some of the most challenging patients that I take care of. There's a lot of considerations pre, peri, and post LVAD that you have to think about specifically related to the kidney. So when I first see these patients pre-LVAD, I think one of the concepts that we really emphasized in the scientific statement was that you know kidney evaluation of kidney function prior to or at the time of LVAD is incredibly important. We know that poor kidney function is linked with poor outcomes, including postoperative kidney dysfunction, a need for kidney transplant, and higher risk of mortality. Um, Also, in those patients who have persistent kidney dysfunction post LVAD, we see other poor outcomes, including infections, thrombosis, and bleeding, related to their LVAD therapy. I think one of the challenges that we face clinically, and the point that was emphasized in the scientific statement, is that it can be challenging to figure out whether the dysfunction pre-LVAD is reversible or irreversible. Unfortunately, we do not have any validated protocols to actually determine how best to optimize the kidney function prior to LVAD. But our group had some suggestions, I think, that are very pragmatic. One is, thinking about circulatory support with inotropes, vasodilators, diuretics, and even temporary MCS can be helpful to optimize kidney function and to test whether the kidney disease is in fact reversible. And I do encourage everyone to look at figure 4, which I think is a really nice framework and in terms of assessing mechanisms that could contribute to kidney dysfunction pre-LVAD, including determining reversibility. So once patients get the LVAD, so what do you do from there? So, this is challenging, but I think this idea of looking at trajectories of kidney function post LVAD is important. There is a lot of heterogeneity in terms of what happens with the kidneys after an LVAD. Some of the studies that our group reviewed did suggest an initial improvement in eGFR and other kidney markers. However, then there was declines in the long term. I would say we still have incomplete understanding of trajectories of kidney function post LVAD, and we need more data in this space. And I do want to remind you that it is possible to develop new AKI post LVAD implantation. We see this as many as 11 to 45% of LVAD patients. We know this new kidney dysfunction post LVAD is linked with poor outcomes. There's a lot of causes to this new AKI that could be contributory. In figure 5 in the scientific statement actually highlights some of these perioperative insults, which can include cardiopulmonary bypass, RV failure, as well as vasoplegia. So I think this figure again is a really nice framework of putting together a differential of what is causing your perioperative AKI and again thinking about reversibility versus irreversibility. Of course, things happen postoperatively as well, which can make the kidneys quite vulnerable and susceptible to AKI after an LVAD implant. And that could include, persistent volume overload, bleeding, pulmonary hypertension, and intra-abdominal hypertension, just to name a few. And I think, also emphasizing the importance of preventing RV dysfunction is very important, not only for the heart, but for kidneys as well. And so, really close attention to hemodynamic monitoring could really help protect the kidneys long term. And then just to bring up a special population that we see very frequently, but when we do, they can be quite challenging, are those patients who do require chronic dialysis post LVAD. And these patients are very complicated for a number of reasons. We know that they have poor survival compared with those who do not require dialysis. And there's risk of additional complications, including infections, complications related to ultrafiltration, bleeding, and thrombosis. I don't want to forget some of the logistical challenges we have in caring for these patients as well.
Yes.
How do we get them actually into a dialysis unit? How do we train staff to feel comfortable to take care for these patients who are not trained in LVAD care? And so I think there's some suggestion that PD or peritoneal dialysis could be a good option for these patients if long-term dialysis is needed. But unfortunately, the data is limited, but I hope that the statement prompts a lot of work in this area. So that's a lot about LVADs, but Wilson, what do you think about kidney and heart transplants? And this is a situation we're seeing more of clinically as well.
It goes obviously uh, goes straight to the transplant
Yeah.
question. Once you get an LVAD, what is the next plan? So the question is really to understand who is the right candidate to actually get a transplant and whether we should do a simultaneous heart kidney transplant versus a transplant itself has been a long-standing debate. It really depends on the patient's stability, the hemodynamic status, the urgency, the tropic and vasodilator requirement, vasopressor requirements. Certainly, we want patient to recover as much as they can, just like any scenario with or without kidney dysfunction. But it has been kind of a growing consensus that anybody with some degree of chronic kidney disease, EGFR less than 45, really should, highlight the potential need downstream and should plan ahead to have this conversation with our patients, and also work very closely amongst cardiologists and nephrologists to try and figure out, do we need, can we actually go through a heart transplant without a kidney? Which is actually nowadays having some more data suggests that may sometimes be the preferred route, particularly if we could identify those that can correct that, heart failure related kidney dysfunction to actually spare the use of an additional organ. The new heart kidney safety net provides this opportunity now, and I think we follow the footsteps of other dual organ transplants who have this ability starting last year to be able to proceed with the potential of renal recovery for people 60 days after their initial transplant for the heart. And if they still had, severe kidney dysfunction on dialysis, then obviously they would, in, be considered listing for the kidney and then get listed. We actually mentioned a little bit about that also in the supplement has a figure that talks about all the routes that go through that. It's still a very, very important conversation between clinicians. Sometimes with our nephrologists, nephrology colleagues say, hey, this is such a long-standing diabetic kidney disease that probably a simultaneous is a good thing. This is actually important because 1 out of 8 transplant patients still develop acutely kidney failure requiring dialysis, very similar to the statistics you see in the LVAD. And the figure five that you mentioned also had the entire spectrum of the perioperative risk and optimization. Table one, we actually outlined transplant specific, particularly with calcineurin inhibitor toxicity, which is a big contributing factor. How do we actually select drugs? We actually had some mentioning about, and of course, there are some renal sparing drugs that is spearheaded by the kidney transplant group that we hope that at some day we can use them. But clearly, the decision making and co-management is important. Our group spent a lot of time talking about that. Nisha, do you want to at least give an overview of at least the last key point, which is really about the co-management?
Yeah, I think this is incredibly important. And I have to say our writing group was a perfect example of this. We had you and we come from different subspecialties, heart failure, cardiology, and nephrology, but we had people with expertise in palliative care and other important aspects of this idea of
Mhm.
co-management and shared decision making. And so our group really tried to outline in the statements the core elements of shared decision making in patients who have this really tough situation with with advanced heart failure and kidney dysfunction. We thought it was very important to engage patients as well as family and caregivers. Obviously, they're cardiologists and nephrologists, but other important team members as well that would be involved with their care. And really focus, a second point we brought up was to focus on the information and knowledge sharing and building consensus on treatment options. It's important to clarify the goals of care that the patient and their family wish to pursue and what they prioritize and reach agreement on these treatments. And then finally, I think an important thread through entire statement is really think about how we can provide optimal care and adapt our care models with the context of health equity and social determinants of health. In all this, we think that patient preferences are the number one thing that should be prioritized. However, decision aids may be helpful to help guide these very difficult conversations. We don't have any specific decision aids available for patients who have kidney disease and heart failure. However, there's been decision aids that are developed in other populations, for example, in the dialysis population, that may be helpful in these conversations. And then, obviously, a big part of this co management includes input from palliative care. And palliative care management is appropriate for patients who are ineligible for advanced surgical therapies. And really, the focus of palliative care is improving quality of life. And I want to stress again that palliative care is interdisciplinary and patient and family centered. Some of the symptoms that our group would be thought was the most important to focus on in palliative care management were those related to volume overload, which becomes particularly challenging and prevalent in patients who have this dual organ dysfunction with the kidney and the heart failure. And so table 2 in our scientific statement actually lists some practical considerations for volume management in these patients who are not eligible for advanced surgical therapy, you can use things like diuretics, dialysis modalities, and other approaches. And obviously, the advantages and disadvantages of each of these approaches should be weighed carefully. So we've covered a lot today,
Yeah.
Wilson.
So, Nisha, what are the key takeaways from the statement? I think it has been a wonderful journey with a truly multidisciplinary committee, writing committee. And what do you think the key takeaways are?
Yes, good point. So I think there's three main takeaways from this, from what we've put together from this statement. I think the first is, it's important to recognize the mechanisms that lead to kidney dysfunction, and know that they can be variable and that there may be different longitudinal kidney heart profiles, or profiles of kidney dysfunction in these patients with advanced heart failure. And when we're thinking about kidney dysfunction, it's important to think comprehensively about what we mean by kidney dysfunction. It goes beyond EGFR to those other markers that you mentioned at the beginning. So that's, I think, point number one. Point number two is I think we need strategic considerations for therapeutic approaches and surgical interventions to obtain the best outcomes for these patients. And so that's really thinking about both organs in parallel and how we can use these strategies and these interventions with careful monitoring of any pre, peri, and post operative surgical intervention, including LVAD or heart transplantation. And then finally, I think the third big message and takeaway from this is really the emphasis on using these multidisciplinary approaches, including palliative care considerations in the care of these patients with dual organ dysfunction. And, a very important theme in this is really making sure that we remain patient centered and we consider all important considerations, including social determinants of health.
Yeah, in fact, this is really complicated. As we are, divulging on these issues, we recognize from the evaluation all the way to palliative management or interventions, different disciplines have very different approaches. So we really thank the writing committee that is actually representative for each of these disciplines to really provide very wonderful input. This scientific statement is going to change the mindset of people in terms of thinking that this is not a terminal problem. This is actually something that some of it could be reversible by all the advances that we have. So please read the paper, and on behalf of the writing committee, thank you very much. And it is actually published now. And so thank you and enjoy.